I'm aware that not everyone here today has adenoid cystic. There are other subtypes as well, but as it currently stands, this is the area we had the most data for, which is why we've looked at it first. Okay, so start with a bit of background. So I thought I'd start by opening this up to the floor. So what are people's understanding when you say quality of life?
As close to pre-cancer as possible, I would say.
Okay. We do have a definition from the World Health Organization. It's quite chunky. And then if we sort of translate this into something a bit more understandable, it's talking about people's well-being. And one of the key things here is that we're looking at well-being at a specific point in time. So if you say about someone's quality of life, it's at the time you ask them about it. And it's also very key to note that it's a subjective thing, so it's how an individual's feeling. No one else could tell you what your quality of life is. Now, the question then is, how do we measure it? And the most important thing is you need to actually ask people, because it's subjective. And there are a few ways of doing this. Romilly mentioned about large questionnaires, so questionnaires is definitely an option. And there are a few ways of delivering these. So a lot of trials still do this with paper, but increasingly we're also using electronic methods as well, which are known as EPROMs. I'll get onto that in a moment. And you can also do it through things like interviews too. So what are EPROMs? It stands for Electronic Patient Reported Outcome Measures. And a lot of you may be more aware of this as the text that we bug you with before you have our appointments with us. So the EPROMs that we actually use as part of the Christie is primarily designed as a clinical tool. So it's to point out things where you might need a bit of help and to give us a pointer as well before appointments. However, it does include parts that are helpful from the research side as well. And we introduced it at the Christie in 2019. It isn't available in all areas, but in the head and neck and therefore the salivary gland, we've got now 5 years of data. This is the form in its entirety when we send it out. So we're talking about long forms, and there is quite a lot of information there. Now, a bit we're going to be focusing on today is actually this last section, and this is something called the EQ5D 5L. And you see here, there's 5 what we call domains, and each one has 5 possible responses. And that's a rank from essentially no issue in a particular problem up to an extreme issue or being unable to do that thing. And we can score this as well, so we can turn this into a number. So having no issue would be a score of 1, and having the worst would be a score of 5. And you get that for each of the 5 domains. There's also this part to it, which is what's called a visual analog scale. And this is a ranking out of 100 for where you think your health is at the point that that form is filled in. And the idea being that 100 is perfect health and 0 is awful.
Dead.
Well, the worst health you can imagine. And again, this is subjective. So the EQ5D5L is internationally validated. It's being used in a lot of different countries around the world. It's not specific to cancer, so it can be used for any health condition. And it actually can be used in people with no health condition as well. And one of the key things about it is that we can adjust the output to match the values of a specific country. So if we go back to that World Health Organization definition, you'll notice it mentions in the context of the culture and value systems in which someone lives. So how we interpret how we're feeling, it depends on where we live and what sort of environment we've grown up in. So how a particular state of being is interpreted in, say, Italy might be quite different to in the UK. So what we can do with the EQ5D is that we can adjust that to match the country. And that means that health state, we then can say this is how we'd expect someone in this country to consider that. One of the important things about it is that it's used by a lot of health technology assessment organisations, in particular NICE, so the National Institute for Clinical Excellence, and they QoL questionnaires, of which this is one, are the preferred tool for them to calculate what's called a QoL. And this is a quality adjusted life years. So this is what they use to decide if a treatment is to be reimbursed on the NHS. So this has a real impact in whether a drug treatment or any treatment becomes available. And prior to this, we don't have a baseline in salivary gland cancers as to what we'd expect the quality of life to be. It's worth noting with that a drug can be reimbursed purely on quality of life improvements. So if it basically makes people feel better, like it's enough to, to a sufficient degree, they may reimburse the treatment. So the way that we do that weighting is we create something called an EQ value based on the scores from the 5 domains. And an EQ value of 1 is equated to ideal quality of life. 0 is a state that's considered to be as bad as death. And in most, so for most countries, that it can go below 0, where they might consider a state to be worse than death. And that's a really, really terrible quality of life. So, moving on to what we actually did in the study. This is looking a little bit at what we did. So, at the time of doing this, we had about 300 patients in the biobank with adenoid cystic carcinoma. Of those, 177 were confirmed to have been sent at least one EPROMS form, and 161 had completed at least one and were included in the analysis. Quite a lot of patients had completed more, so the average was 2 forms at different points in time. I think there was one patient that had over 20. So we've got quite a lot of data over time, which is really helpful for this. We then used that information to calculate the EQ values, and we did a couple of different statistical analyses to look at that. In particular, we looked at the relationship between quality of life and risk of dying, as well as what other factors or covariates might impact that quality of life as well. So, in terms of the spread of people, so the average age was about 50, which is quite typical for adenoid cystic. And in general, about a third of patients, it was in the major salivary glands, with the rest being in other parts of the body. And we did get a spread for most of the areas that adenoid cystic can appear. About 2/3 were female. There were also 8% of people that had a Notch1 gain of function mutation confirmed. And these are patients that we know generally have a more aggressive form of the disease, that we were hypothesizing might have a worse quality of life. When we look at the distribution of all of those domains we were talking about, we can get this graph. And you see that in general, people tended to be towards the better quality of life. So that's towards the top of the graph where most of these areas are wider. In the purple one at the edge for the EQ value, we do have an orange line for the general population, so across the board in the UK. And then the black dotted line is for the people in the study. So quality of life in adenoid cystic carcinoma is a bit worse than the general population, but not massively so. And this is pretty comparable to other cancers as well. Now, when we looked at this in a proportional hazards model to look at the risk of death when related to quality of life, what it showed is that having a significantly worse quality of life does increase the risk of somebody dying. And what that numbers that are highlighted, so the hazard ratio there means that if you went from a quality of life, so an EQ value of 1 to an EQ value of 0, we'd expect an 8-fold increased risk of death, approximately. Now, it is a little bit more complicated than this, because it turns out that the relationship isn't a straight line. And you can see that in this graph, where the gaps between those lines aren't even. So there is a bigger impact on your risk above the sort of 50% mark. We then looked at the other variables that might impact this. And in particular, what this showed is that quality of life gets worse over time because the slope was negative. And that was the only factor we found that significantly affected quality of life out of the ones that we were able to look at. And in particular, we had, these are the other factors that we looked at, and none of these were found to have a significant bearing, including Notch 1 status, which we were a little bit surprised by. And what that means in summary is that the lower quality of life was associated with an increased risk of dying. The relationship isn't that straightforward. And that time is the only factor we found that was significantly worsening that. So that sort of led us on to the logical next question of what, can we do something about this? And the real question there is if someone is found to have a low, poor quality of life, if we improve that, does it then reduce that risk of dying? And similar to what Dr. Berman was talking about in the presentation earlier, there is evidence in a general sense that good supportive care does improve life expectancy with cancer, in the absence of anti-cancer treatment specifically. So we think that it is likely that if you do engage with supportive care and we can improve the quality of life, that you would expect that risk to then reduce. But we don't know that at the moment. So the next thing that we're going to be looking at is doing a pilot study to sort of investigate that. The other thing that would be useful is to look at this in other salivary gland subtypes, but we'll probably need to collect a bit more data before we're able to analyse that with any strength.